quickly realized what's the first and one of the biggest enemies of dental implant treatment. It's definitely the lack of bone volume. Exactly as many others, I started with different GBR techniques, but unfortunately, I didn't succeed. After some time, I found, I would say today, the most forgiving technique at all. Why? Because it's working with the best material ever. Do you know what I mean? Then good things started to happen. Kopacka. I came from Slovakia, Central Europe, and today I'd like to share my case in this amazing competition, Megamind 2024. The topic of my presentation is reconstruction of severely atrophic frontal maxilla. When my patient came first into my office, I saw big and really tough guy. Both hands were covered by tattoos. But even though he cried as a child, literally, and I immediately got it, how much pain and how big frustration is hidden behind his strong body. Patient was 34 years old male patient when we started the treatment. His chief complaint was missing teeth in his frontal maxilla for a long time. Generally, he is young. He has to be young because I'm 35. And healthy man with no disorders, and even he quitted smoking because he wanted to get teeth again. Clearly, huge gap in his frontal maxilla, the most struggling part for the patient, and also multiple missing teeth in both jaws. Clinically, we can just confirm that situation. There is huge gap in his frontal maxilla and short gap on the edge of aesthetic region. When I saw him for first time, my very rough and very first plan was to place 3 implants in his frontal maxilla in region 1-2, 2-2, and 2-4, and 1 more implant for replacing right upper premolar or short bridge supported by teeth. I imagine that situation from the frontal point of view. I saw these 3 implants in position 1, 2, 2, 2, and 2, 4. But guess what? When we took CBCT scan, there is definitely the lack of bone volume. In region 1-2, there is horizontal bone loss. There is no way how to place implant without any kind of bone augmentation procedure. In region 2-2 was the situation even worse because the crest was even thinner. And in region 2-4, there was the worst situation because there was not only horizontal, but also vertical bone loss, and there was combined 3D defect. Treatment plan was based on general rules of any kind of bone augmentation procedure. First of all, it was necessary to get rid of this patient of all infection sources and to learn him how to keep his teeth clean. After this crucial step, this patient had to underwent again professional teeth cleaning at least 1 week prior surgery, and he started to rinse with chlorhexidine 3 times daily. Because we were planning to work and to regenerate the bone in quite wild oral environment, we had to prescribe antibiotics, and this patient was under antibiotic prophylaxis. So he started with amoxicillin 1 day before surgery, and then he continued next following 14 days till soft tissue was closed. The very important step was 3D vertical and horizontal bone augmentation according to Professor Curry and also modified by Professor Gluckman. Professor Howard Gluckman describes over here his beautiful so-called bending or curving technique, which describes bending bone plates for using and curved bone defects in the anterior maxilla. But let me explain later. After bone healing, what usually takes 4 months, we placed 3 implants in required position. And after the osseointegration period, we do some soft tissue correction. And the most important step for each patient, the prosthetic phase, of course. So let's go to the bone augmentation. We can see here open flap, exposed bone, where is definitely bone loss in region 1-2, bone loss in region 2-2 in horizontal way, and in region 2-3 and 2-4, definitely 3D combined bone defect in vertical and horizontal way as well. For cases such like this, I prefer to use donor side of choice, what is usually external oblique line, or also called retromolar area. This area offers sufficient amount of bone volume with the least chance to injure some vital structure. I also harvested these bone blocks with a piezoelectric device, even though it's approximately 2 times slower, but it offers sufficient cooling, less chance to overheat the bone with future osteonecrosis, and it makes this procedure even more delicate. So I harvested 2 bone blocks. Each bone block was taken from each external oblique line. And because it's called split bone block technique, according to Professor Curie, I split this bone block into 2 thin parts, so-called bone plates, and I use this diamond-coated disc, with sufficient cooling, of course. In that way, we got these beautiful form bone plates. This bone plates works only as a biological membrane, but the pure gold, the real gold, is over here in this bowl. So next step was scraping and collecting bone chips from bone plates first, then from donor side as well, intraorally, and storing them under sterile saline solution in the surgical bowl to avoid any drying out of these bone chips. Then I prepared all bone plates in terms of getting rid of all sharp edges, corners, and smoothing all parts. This bone plate was also prepared according to Professor Blackman, and thanks these small curvings created by this diamond-coated disc in the middle part of this bone plate, allowed to shape this bone plate to bend it according anteriorly curved maxilla. We can see over here the way how I fix these bone plates. On the right side of the picture, we can see 2 parallelly positioned bone plates. Why? Because it's the region of vertical bone loss, and we had to gain the bone volume also in height, not only in thickness. I used their banded bone plate. On the left side of the picture was just horizontal bone loss. So then we did there some boxes from buccal side of the crest. All the containers which we created was then filled with bone chips. These bone chips were condensed properly till we feel 1 complex unit under our fingers. Next following step was, of course, wound closure, and I prefer to use PTFE suture material. And in this case, I used double layer closure. First layer was composed by external averting horizontal matrix sutures, and then single interrupted sutures over it. On that panoramic X-ray, we can clearly see both harvesting sites and 10 microscrews holding the whole framework in right position for proper healing in this bone augmentation case. After 4 months of healing, I exposed the bone again and look at this beautiful reddish vascularized patient's own bone with its own immune system. We can compare the situation beforehand and afterwards, and there is definitely a huge difference. It was not an issue to place 3 implants in required positions, so I placed 3 megagen implants, and then I sutured this wound again with PTFE suture material. We can see here all implants on panoramic X-ray. And after the osseointegration period, what takes usually 3 months, we should proceed that case with soft tissue management. And I love this procedure with after all maxillary cases, because we have never ending. We have endless source of keratinized mucosa on heart palate. So this technique is called apical repositioned flap. So I started palatally at least 5 millimeters from each buccal surface of implant and shift this palatal mucosa to the buccal side of each implant neck. Of course, this procedure is connected with implant uncovering. So I replaced all covering screws with healing abutments. But look at this common issue in this case. This is the discrepancy between inner circle and outer circle. What happens usually in anterior maxilla. I had to solve this problem. So I divided this flap, this shifted flap, into 3 portions. And I sutured then each portion to make it periosteum without muscle fibers to each implant neck. I used 6-0 suture material, monofilaments. Here is more buccal view. And here is the result after 14 days of flap repositioning. So healing is very, very fast. Here are some X-rays after replacing cover screws by healing abutments. And then we can proceed that case with prosthetic phase. What's the most important for each patient. So I followed my very first treatment plan. So I prepared this teeth for a short bridge supported by teeth. And these implants were prepared for scanning and for prosthetic phase and creating some implant supported bridge. Look at this incredible amount of soft tissue. Look at this incredible amount of bone. I love these procedures. I love all augmentation, all autogenous augmentation procedures because it's still the same story. It's like Robin Hood, taken from the rich and given to the poor. Then we continue with
Recording
scanning.
stopped. Recording in progress.
And our lab fabricated this beautiful prosthetic work. Actually, 2 prosthetic works. They are separately on teeth and separately on implants. And look at this picture. So this is immediately after fixation. Of course, patient forgot how to clean his teeth, probably. And here is comparison before the treatment and afterwards. Here is the picture after 4 months. So 4 months follow-up. This patient, in each single life are the most important 3 milestones. When you are born, when you'll die, and when you'll be buried. This patient died in his 34 and he started to live again in his 35. Thank you for your kind attention, and I would like to wish best luck to all participants of this beautiful competition, the Megamind 2024. And if you'd like, you can scan my QR code and follow me on Instagram. Thank you.